So our today's lecture is on breast radiotherapy, and we have excellent speakers, Dr. Кейт Хорст and Jonathan Lewis. Dr. Horst, she used to be a resident here at Stanford, and now she's a full professor specializing in breast radiotherapy. Her interests are also partial breast radiation and intraoperative radiation. She's also a recent fellow of ASTRO. Congrats, Kate. And she's also a recipient of Richard Hoppy Leadership Award. And Jonathan Lewis is our amazing chief dosimetrist. He's a recipient of numerous teaching and leadership awards, and he will be teaching us on breast planning at the end of the session. Since there's a lot of material to cover, this is an extensive topic. We extended the time for this talk to an hour and a half. So without further ado, take it away, Kate. I'll stop sharing.
Okay, great. Thank you, Natalia. Okay. Great, wonderful. Thank you so much for the opportunity to present this overview on breast cancer. So I thought I'd go ahead with the outline that Natalia had suggested, looking at epidemiology, anatomy, and risk factors, histology, diagnosis and workup, staging, treatment, side effects, and then future directions. So breast cancer is the most frequently diagnosed cancer and the second leading cause of cancer-related death in women in the United States. So these statistics are taken from evaluation here in the United States. And we know that over the last 40 years, you can see in this curve over here, that the incidence has continued to rise. But fortunately, our outcomes are all overall very good. In the United States in 2023, there were about approximately 298,000 cases, and the lifetime risk for women in the United States is now 1 in 8. The median age of diagnosis is 61 years, and about 2/3 of the patients actually have no significant risk factors. Here at Stanford, we end up actually seeing women who are diagnosed even at a younger age. There are some men who develop breast cancer. However, male breast cancer accounts for only about 0.5 to 1% of all breast cancer cases in the US. And I probably see maybe 1 or maybe 2 men with breast cancer each year. So looking at the anatomy of the breast, the lobe or the lobules is where the milk is produced, and then the ducts is the transport of the milk to the nipple. So we have 2 types of breast cancers that are commonly developed: lobular breast cancer and ductal breast cancer, depending on where in the breast it develops. The breast cancer drains to the lymph nodes in the axilla, which then sometimes can also drain to the high axilla and into the supraclavicular region. And we label these axillary regions according to the location relative to the pectoralis minor muscle. So level 1 lymph nodes are lateral and inferior to the pec minor, level 2 are posterior to the pec minor, and level 3 axilla are superior and medial to the pec minor, with the supraclavicular nodes lying right above the clavicle. Breast cancer can also drain to the internal mammary nodes, which is the chain of lymphatics right along the sternum. And we see this particularly with medial tumors, so tumors located in the medial breast or even in the central breast. So that's another area that we focus our treatment on. So what are some of the risk factors for breast cancer? Well, estrogen exposure has been noted to be to increase the risk of breast cancer, and particularly hormone replacement therapy. Now, interestingly, years ago, it was thought that after women went through menopause, that hormone replacement therapy was actually beneficial in helping with heart disease. But unfortunately, it was found to increase the risk of breast cancer. So now people are cautioned in thinking about taking hormone replacement therapy. It's been a little bit more controversial with oral contraceptives, but as it has not been consistently shown to increase the risk of breast cancer, but there have been some literature and changes in the literature on whether or not that is associated. About 20 to 25% of women diagnosed with breast cancer have a positive family history. So that's something when we evaluate patients, we want to ask them about their family. However, only about 5 to 10% of breast cancers are genetically related, with BRCA1 and 2 being kind of the mutations that we've have the most experience with. And in these patients, they have a 60 to 80% lifetime risk of developing breast cancer. With some of the larger panels that we now see, we have identified a lot of other genetic mutations that have conferred an increased risk of breast cancer as well. Now, some women have a personal history of abnormality, so they've seen in the past biopsies where they showed atypia of the breast or lobular carcinoma in situ, and we know that women with denser breast tissue have an increased risk of breast cancer as well. And other lifestyle factors have been identified, such as the alcohol use, obesity, and a sedentary lifestyle. And for those of us in radiation oncology, we're really attentive to those young girls and young women who were treated, for example, for Hodgkin's disease, who were treated with radiotherapy to the chest, and they have a high risk of developing breast cancer in their lifetime. So these women are followed very closely. I mentioned some of the genetic mutations associated with increased risk of breast cancer. As I mentioned, BRCA1 and 2 are kind of the oldest mutations that have been identified. And more recently, with these larger panels, have seen patients coming through with these other mutations. So they're screened very closely, as well as for other cancers. So when a patient is diagnosed with breast cancer, we often refer them to our genetic counselors for genetic testing, particularly if they are young. So women under 50, the NCCN, or National Comprehensive Cancer Network, recommends referral for genetic testing. Other groups that are recommended for genetic testing include those diagnosed with triple-negative breast cancers, because they are often associated with BRCA1 mutations, or if there are multiple breast cancers, either bilateral breast cancers or at the same time or synchronously. The other area, male breast cancers, is almost always referred for genetic testing. And then again, those who have a strong family history. Most breast cancers, however, are detected on routine screening mammography. There are a few patients who do develop symptoms, such as a palpable mass, skin retraction, or nipple discharge. And so those women are referred for further workup. Often the mass is painless, although sometimes it can have pain. And then the nipple discharge can be bloody or clear, either of which should be referred for further workup. Now, a lot of times patients can also be diagnosed with either multifocal or multicentric disease, which is defined as either 2 or more foci in the same quadrant or 2 or more foci in different quadrants of the breast. And that can dictate further management. Now, there's been a lot of controversy, and most recently in the US, at least, the USPTF, the US Preventive Task Force, has kind of changed their guidelines, whereby they now recommend starting screening mammography at the age of 40 and stopping it at the age of 74. They've now recommended every other year. However, other groups, including the American College of Surgeons and the NCCN, the National Comprehensive Cancer Network, which is what we here at Stanford go by, recommend starting at 40 on an annual basis and continuing as long as someone is healthy. It's sometimes hard to know when to stop, but as long as women are active and healthy and have no comorbidities whereby they would die in the next several years, we continue screening so that we can ideally identify cancer early. Now, I wanted to kind of highlight the difference between screening and diagnostic mammography. Screening mammography is where someone doesn't have any symptoms or complaints, and the mammographer will just do, sorry, a big popped up. The mammographer will just do 2 standard views of each breast, cranial caudal or CC view, and the medial lateral oblique view. A diagnostic mammography is used when somebody has symptoms. So as I mentioned before, they have a palpable mass, they have nipple discharge. This warrants additional views so they can focus on that specific area, and they also introduce an ultrasound. And our diagnostic radiologists are reviewing it in real time and discussing it with the patient. Now, one of the things you'll see in reports, at least in the United States, they now have what we call BI-RADS, or breast imaging reporting and data system. They use this as a systematized way of communicating what their level of concern or risk might be. So usually with routine screening where you don't have any abnormalities, the BI-RADS 1 or 2 would be a negative or benign. And when we start to see something that's suspicious that is recommended for biopsy, then it's given a BI-RADS 4, and that leads to further evaluation. Mammography traditionally had been 2D imaging, but now we have the use of tomosynthesis, which is where they kind of arc around the breast and are able to reconstruct so they can scroll through the breast tissue. And you can see in this example how it really highlights an abnormality that otherwise would have been obscured in the density of the breast tissue. Other imaging modalities that we incorporate is an ultrasound. So you can do this with a transducer in a focused area. We also have now automated whole breast ultrasound, which can screen the entire breast using a whole breast ultrasound approach. And then here in the United States and at Stanford, we use quite a bit of magnetic resonance imaging, which is magnetic imaging with the use of IV gadolinium. And you can see that the abnormality jumps out very well here after given contrast enhancement. Now, breast MRI is somewhat controversial, and we often use it with diagnostic workup, although it sometimes can be used for screening women. It's very sensitive and more sensitive than mammography, but not as specific, so it has a higher rate of false positive findings, meaning that we sometimes have to biopsy things that aren't actually significant, but we don't know that until we proceed with the biopsy. The American College of Surgeons recommends screening MRI for women at high risk of breast cancer, which includes those with those mutations that we mentioned before, those with a strong family history of breast or ovarian cancer, and now pretty routinely those who've had that thoracic radiotherapy for prior treatment as a child, or even under the age of 30, where we know that they're at high risk of breast cancer. The breast MRI can identify that earlier than mammography. So once somebody is identified with an abnormality on imaging, then they go on to a breast biopsy. Typically, it's a core needle biopsy, which is an outpatient procedure under local anesthetic. And it's guided by mammography if it's only seen by mammography, ultrasound if you can readily identify it on ultrasound, or if it's only seen on MRI, then we have the capability of doing the core needle biopsy under MR guidance. And it's a small cut in the skin, and they typically deploy a clip at the biopsy site for further identification. Now, histologically, the different types of cancer can be either in situ or invasive. Ductal carcinoma in situ is where you have some abnormal cells in the duct, but they're still within the duct. So you can see here there's intact membrane. So you can see that it's abnormal cells, but nothing has invaded into the breast tissue. Alternatively, when we have invasive cancer, as I mentioned previously, there are two types, are invasive ductal or invasive lobular. Invasive ductal carcinomas have started in the duct, but then now has invaded through the membranous lining and now invading into the breast tissue. This is the most common type of invasive cancer, comprising about 70 to 80% of lesions. Invasive lobular, in contrast, is only about 8 to 10% of invasive cancers, and they look quite a bit different. They start in the lobules of the breast, and they often are in like a single file lining. So it looks quite a bit different than the ductal cancers. There are other kind of nuanced breast cancers that we sometimes see, which comprise only less than 5% of all breast cancers. However, we often treat them very similarly, and I'll go into that in a little bit. When we're looking at the pathology report, we want to focus on a couple different things. One is the grade, which is put together based on how much it looks like normal cell structure, how different do the nuclei look from normal cells, and how fast are the cells dividing. And we categorize them as grade 1, 2, or 3. And this really gives us prognostic information. We also look at what's called the Ki-67, which is a marker of proliferation, so how rapidly dividing are the cancers. And then we also look at lymphovascular space invasion. That is, are the cells already into the lymphatics or the blood vessels of the breast tissue? Again, giving us prognostic information. Now, with breast cancer, we also want to look at some molecular markers, particularly estrogen receptor, which is a protein that many cancers express. And we look at it through immunohistochemistry and looking at the percentage of cells that are staining positive for the estrogen receptor, as well as the intensity of staining. Similarly, the progesterone receptor is analyzed by IHC. And we also now look at human epidermal growth factor receptor, which is evaluated both by immunohistochemistry, which looks at protein overexpression, or in situ hybridization, which looks at gene amplification. And these molecular assays really help guide our treatment decisions. Years ago, the breast cancers were identified as various molecular subtypes, looking at gene expression profiling. So this was done in the early 2000s. And at the time, there were 5 intrinsic subtypes that were identified: luminal A, luminal B, normal breast-like, HER2-enriched, and basal-like. And since then, there have been some other additional subtypes added. But in the management of breast cancer, we often use the ER, PR, and HER2 expression as surrogates of these molecular subtypes. So luminal A is often defined or characterized as a tumor that is ER, PR positive, HER2 negative, and has a low proliferation. Luminal B can be ER, PR positive, and it can be HER2 positive or HER2 negative, but has a high proliferation. And these tend to be quite a bit more aggressive. HER2 enriched is usually ER, PR negative and HER2 positive, and basal-like is often the ER, PR, and HER2 negative or triple-like breast cancers. And why is this important? Well, we know that in general, this can guide our prognosis, it can guide our treatments, and we also know from a local regional standpoint that these cancers behave differently. We often have much better local control with the luminal A or the ER positive tumors, and not so much with the triple negative or the ER, PR, and HER2 negative tumors. So we often are looking at this very differently in terms of how aggressive we should be in management of these cancers. So first question, I was trying to be a little bit simple here. What type of breast cancer is triple negative? We have ER positive, PR positive, HER2 negative, ER positive, PR positive. Oh, excuse me, that was supposed to be HER2 positive, ER negative, PR negative, HER2 negative, and ER negative, PR negative, HER2 positive. Sorry, the typo. Number 2 should be ER positive, PR positive, and HER2 positive. So I tried to make this one easy, and those of you know that triple negative just means they're all negative, and that is number 3. So what about treatment? First in breast cancer is typically surgery. Now, we use different terminologies. Lumpectomy is commonly used to indicate removal of the lump plus a margin around the tissue, around the tumor. You'll also hear the term breast conservation surgery or BCS. And many times in Europe, they'll call it quadrantectomy, where they're removing a larger area of the quadrant. And this is in contrast to mastectomy, which is removal of the entire breast. We also, for invasive cancers, evaluate the lymph nodes. Historically, it used to be an axillary lymph node dissection, which is removal of a larger area of lymph nodes. And now more routinely, we do a sentinel lymph node biopsy, which is removing just a few lymph nodes. With radiotherapy, we often do adjuvant treatment after breast conserving surgery, and we sometimes do radiotherapy after mastectomy with large tumors or those with lymph node involvement. And if we're looking at treatment after breast conserving surgery, we define it as either whole breast radiotherapy or partial breast radiotherapy. Patients will then be evaluated for whether or not they have benefit from chemotherapy, and this is particularly for triple-negative cancers and those with HER2-positive cancers. And those with ER-positive cancers will then go on to hormonal therapy, either tamoxifen or aromatase inhibitors. So as I mentioned, mastectomy, which is removal of the entire breast, historically was this radical approach called the Halsted mastectomy. This was years and years ago, removal of not only the breast, but also the pectoralis major and minor muscles, as well as removal of all 3 levels of the axilla. Of course, it's rarely used today, as it was very disfiguring and very challenging functionally with removal of the muscles. And we now know that we don't need to remove the muscles, and we can get good control with just removing breast tissue. So the modified radical mastectomy came into play, where the pectoralis muscles were preserved and only the breast and level 1 and 2 of the axilla were removed. More recently, we now very commonly with a sentinel lymph node biopsy will see patients undergoing a total or a simple mastectomy, which is really removing the breast tissue only, and then often with a sentinel lymph node biopsy. You'll also sometimes see the term skin-sparing or nipple-sparing mastectomy. So skin-sparing mastectomy is where they remove the breast but preserve a larger area of the skin. And nipple-sparing mastectomy is where they're actually preserving the nipple areolar complex. And this is often done when a patient is undergoing reconstruction. And that allows a more natural or normal appearing look to the breast, as you can see from this diagram. Now, reconstruction can either be a tissue expander or implant-based reconstruction, whereby the plastic surgeon will place this expander, will fill it with saline. Often we do radiotherapy with the tissue expander in place, and then several months later, they will exchange it for the permanent implant. Or we sometimes see what we call autologous flap reconstruction. That is where the plastic surgeon will take tissue from the abdomen, the latissimus dorsi, or even now here at Stanford, our surgeons are looking at using an omental flap. So they go in and take some tissue from the omentum and reconstruct the breast mound using that omental tissue. So these are the various reconstructions that we see. Lumpectomy, the other term that you sometimes will see is called partial mastectomy. So again, removing just the tumor with a rim of normal tissue around it. And it has been shown in several randomized trials to be equivalent to mastectomy in terms of overall survival. So now with small tumors, we will often offer this to patients. In either case, as I mentioned with the mastectomy, but also with the the partial mastectomy or lumpectomy, if we have invasive cancer, we will evaluate the lymph nodes. In the past, as I mentioned, they would do a full dissection of the axilla, but now patients are often undergoing a sentinel lymph node biopsy. This is where the surgeon will inject a radioactive tracer or a blue dye into the breast, and then the radioactive tracer or the dye will track to the sentinel node. That is the first draining echelon of nodes. The surgeon will then go in and using a probe to identify the radioactive tracer or visually identify a blue node, will just dissect out those nodes and evaluate for whether or not there's tumor involvement. The advantage of the sentinel lymph node biopsy is you're only taking a few lymph nodes, and it decreases the risk of lymphedema or arm swelling. So it's been a significant change over the last several years. So when we're staging breast cancer, we look both at the tumor size, which is the T stage, tumor size, or whether it's invading into the skin or the chest wall. And we look at the status of the lymph nodes. So whether or not the lymph nodes are involved, and if they're involved, how many are involved. This gives us staging information and helps with prognosis. Stage 0 in breast cancer is actually DCIS, so in situ disease. It has a very, very good outcome. Stage 1 and 2 disease is early stage with only limited nodal involvement, And stage 3 is when there's more advanced nodal involvement, with stage 4 being metastatic disease to other organs. In breast cancer, we're also now incorporating other information for prognosis, including grade, ER, PR, and HER2 status. So after a patient undergoes surgery, then they will often be evaluated by a medical oncologist to discuss systemic therapy. And the first branching point is whether or not they would benefit from chemotherapy. As I mentioned, almost all triple-negative breast cancers will get a recommendation for chemotherapy, as will those with HER2-positive breast cancers. And this can be done in an adjuvant setting, so they go for surgery followed by chemotherapy, or in the neoadjuvant setting, whereby they get chemotherapy first and then go on to surgery. And this has been interestingly, increasingly being used in the triple-negative HER2-positive setting, because we know that if women have chemotherapy and then go to surgery, those who have a complete response, what we call a complete pathologic response, do much better long-term than those who have residual disease, as you can see in these curves. The blue curves are those who did not have a complete response, who have much worse event-free and overall survival compared to those who have a complete response. So this is another way of helping guide prognosis and additional treatments for these patients. Now, for ER-positive tumors, it used to be that many of them would also have gotten chemotherapy, particularly if they were node-positive. But with the introduction of gene expression profiles, this has really changed. So the one that we commonly use here at Stanford is called the Oncotype DX. This is looking specifically at ER-positive, HER2-negative tumors, and it's a 21 gene assay that can predict the benefit of chemotherapy in addition to hormone therapy or endocrine therapy. There have been 2 trials looking at this, both in the node-negative and the node-positive setting, and it now gives us a score and a better understanding of what benefit, if any, a patient will have with chemotherapy. So in the node-negative setting, those who have a recurrence score of greater than 25 will get a recommendation for chemotherapy. However, those with a recurrence score less than 25, we now know from this trial that chemotherapy adds little to no benefit and only adds toxicity. Now, in the node-positive setting, where almost everyone got chemotherapy in the past, we now then know that from this responder trial that postmenopausal women do not have benefit from chemotherapy. There is still some benefit in premenopausal women, so they will also often get chemotherapy recommended to them. The other gene expression profile assays that are out there are called the MammaPrint, which is a 70 gene test, and Prosigna, which is a 50 gene test. So I know other institutions commonly use these assays. And when we're looking at local regional disease, which is what as a radiation oncologist we're focused on, we don't yet have prospective data looking at the role of Oncotype in guiding us. However, we do have some retrospective studies that have demonstrated that indeed the Oncotype does seem to correlate with local regional recurrence risk. So you can see here in these curves that in the node-negative patients, the gray curves are the high scores and the blue curves are the low risk scores. So definitely the low risk scores do tend to have a lower risk of local regional recurrence. And this is also true in the node-positive setting, where the high recurrence score definitely has a high risk of local regional recurrence compared to the low risk score. And I'll talk about a trial ongoing a little bit later that's looking to incorporate the Oncotype in our decisions about radiotherapy. So after they make a deciding point about whether or not to do chemotherapy, for those who are ER positive, they then go on to either tamoxifen, which is typically in the premenopausal setting, or an aromatase inhibitor, which blocks estrogen production in women who are postmenopausal. We now see a lot of patients at high risk of recurrence getting additional treatments, what's called CDK4/6 inhibitors, which are used in combination with endocrine therapy to try to minimize resistance to endocrine therapy. And as I mentioned, with HER2 positive tumors, they are now routinely, in addition to getting chemotherapy recommendations, are also getting HER2 targeted therapy. In the triple negative setting, we now have data showing that immunotherapy also improves outcomes. So this has really changed over the last several years for the management of triple negative breast cancers. Now, what about radiation therapy? As radiation oncologists, this is our area of focus. And I wanted to kind of highlight how we go about evaluating patients for radiation therapy. We have several patients who are now candidates for omission of radiotherapy. And for early stage disease, whether it be DCIS or early invasive cancer, we then evaluate patients for whether they're a candidate for whole breast radiotherapy or accelerated partial breast radiotherapy after lumpectomy surgery. In node positive patients, we then often will discuss the addition of regional nodal irradiation in addition to breast radiotherapy. And in those who are lymph node positive or have large tumors, after mastectomy, we will discuss whether to add chest wall and nodal irradiation for those patients as well. So what about omission of radiotherapy? For ductal carcinoma in situ in particular, we now have good data from this Energy RTOG trial that looked at low risk DCIS, which was defined as grade 1 or 2, measuring less than 2.5 centimeters. And these women were randomized to radiotherapy or no radiotherapy after lumpectomy. You can see the curves on the right here in the upper right-hand corner. This is the risk of recurrence within the remaining breast tissue. The blue curves being without radiotherapy and the red curves being with radiotherapy. So we know that radiotherapy reduces that risk of recurrence, but now at 15 years of follow-up, the risk of recurrence without radiotherapy is only about 15%. So while we used to routinely recommend radiation for everyone with DCIS, we will now have individualized conversations based on whether somebody feels that this risk of recurrence is high enough to warrant radiotherapy, or whether in their lifetime that is a reasonable risk. For example, if someone is in their 70s or 80s, this might not be an unreasonable risk for them to consider no radiotherapy. Now, what's important when we're talking about radiotherapy for DCIS is the risk also of invasive cancers. So no one dies of DCIS, but it's the invasive cancer that is life-threatening. And indeed, radiotherapy reduces that risk of invasive cancer. But again, depending on the age of the patient and other comorbidities, it may be reasonable to avoid radiotherapy after lumpectomy for DCIS in some patients. Similarly, in invasive cancers, we have two studies now looking at women over the age of 70, and from the PRIME2, which is out of the UK, looking at women over the age of 65, whereby they were randomized to whole breast radiotherapy or no radiotherapy. And at 10 years of follow-up, both studies showed that the risk of local regional recurrence without radiotherapy was only about 9 to 10%. With radiotherapy, that was reduced to 1 to 2%, but again, not a very high number, and some patients may wish to forego radiotherapy with a slightly higher risk of local regional recurrence, but no impact on survival. So these are the conversations that we'll have, particularly with these older women. There are several studies going on, both in the United States and globally, looking at, again, trying to identify low-risk patients who might be able to safely omit radiotherapy. And those two trials I just presented looked at older women. These trials are looking at women in their 50s and 60s using different biomarkers to try and identify low risk. Both the oncotype and the prosigna are being used. And in Canada, they were looking at luminal A-like tumors as defined by the ERPR, HER2, and Ki67. In the United States, there's now an ongoing randomized trial looking at these women in their 50s and 60s with early stage node-negative tumors that have a low oncotype score. And if they have an oncotype less than or equal to 18, they are randomly assigned radiotherapy in addition to hormone therapy, or no radiotherapy and hormone therapy alone. So this trial is currently ongoing and will give us a little bit more information about whether we can safely omit radiotherapy in younger women who have a low oncotype score. But some women want to reduce the risk of recurrence. So for those who choose radiotherapy, we now have various options to offer them. Whole breast radiotherapy is commonly recommended, and historically it was done over the course of 6 to 7 weeks. We now have good data from Canada, which is the curves on the left here, and the UK, showing that we have similar recurrence rates and equal or even less toxicity with a shortened fractionation schedule. So the Canadian study looked at 42.56 gray in 16 fractions compared to 50 gray in 25 fractions. And the UK trial looked at 40 gray in 15 fractions compared to 50 gray in 25 fractions. Interestingly, however, in the United States, it has been slow to adopt. In the United States, you can see this is the hypofractionated whole breast irradiation group compared to conventionally fractionated radiotherapy. It's starting to go up, and this report published in 2022 kind of went through 2016, but surprisingly is a little bit slower in the United States compared to Canada and the UK. And this is actually an interesting survey that was done in Europe, looking at radiation oncologists between October 2019 and March of 2020, and how many radiation oncologists utilized hypofractionation in various settings. And you can see the darker here, where 75 to 100% of the time they would use hypofractionation in the whole breast irradiation setting, and less so when people started adding regional nodal radiation or in the post-mastectomy setting. But you can see there's a lot of variation across the different countries. And here, more individually, looking at the countries that utilized hypofractionation and what percentage of the time versus conventional fractionation, which is in the yellow. So it's kind of interesting to see that over time, some countries have been more readily adopting it, and other countries a little less so. I think this was very interesting. In 2020, the UK published their study looking at a 1-week course of treatment called the Fast Forward study. This was comparing 40 gray and 15 fractions to 2 5-fraction regimens of 26 gray or 27 gray. They found that local control was equivalent. However, there was poorer cosmesis in the 27 gray and 5-fraction arm. So they now concluded that 26 gray in 5 fractions over 1 week was equivalent to 40 gray in 15 fractions. And interestingly, these came out in 2020, which of course was when the pandemic hit. So as this was published in the Lancet in April of 2020, and of course in March of 2020, when the pandemic hit, in the UK, they published guidelines for radiotherapy during COVID. And in the same week, they published advisory documents where they recommended the use of 26 gray and 5 fractions for the adjuvant treatment of early breast cancer. When they went back and surveyed in April of 2020, almost 61% of breast radiotherapy courses used this fractionation schedule, which compared only a year prior to 0.2% of courses. So in the UK, this was readily adopted and is used pretty routinely. Okay, next question. Which hypofractionation schedules are appropriate for whole breast radiotherapy? 42.56 and 16, 40 and 15, 26 gray and 5 fractions, or all of the above? Yes, correct. So all of the above. And we now know that these two, based on the Canadian and UK trials, are acceptable. And then in a 5-fraction regimen, 26 gray was the winner as opposed to 27 gray. So now you might see these fractionation schedules being utilized more readily. In addition to whole breast radiotherapy, for those who choose radiotherapy, we sometimes discuss partial breast radiation. And this has evolved over the last several years, whereby the terminology APBI, or accelerated partial breast irradiation, came about because the dose was now delivered in 1 to 5 days, as opposed to several weeks, and partial breast being differentiating the volume of breast. So instead of delivering treatment to the whole breast, it's only to the surgical cavity plus margin. And there are lots of different trials that have looked at whole breast radiotherapy versus partial breast irradiation. And this group looked specifically using an external beam radiotherapy, using either a 3D conformal approach or an IMRT approach. And most of these trials looked at comparing fairly favorable groups of patients, so older patients with small tumors, mostly node negative, and using different fractionation schedules. So it is now considered acceptable to discuss partial breast irradiation in many patients. But there's been a lot of controversy on that, and at least in the United States, there's been discussion about which patients should we consider partial breast for. And ASTRO initially convened a panel in 2009 and was very, very conservative in their guideline recommendations. In 2017, they updated it, and there is actually an update coming out on board very soon. And right now, the guidelines kind of basically say it's appropriate to use partial breast irradiation for older patients, defined as those over 50, who do not have lymph node involvement and have small tumors that are ER positive, or are low-risk DCIS patients. Cautionary and unsuitable patients include those who are younger with larger tumors, and certainly those with lymph node involvement. So this guideline is being updated, probably coming on to publication in the next month or so. So it might change a little bit, but this is where we are today. So right on that, my last question is, which patients are appropriate for partial breast irradiation? Those with lymph node involvement, those with tumors less than 2 centimeters, those with skin involvement, or those under the age of 40? Try to make these fairly straightforward. Excellent. So number 2, those with tumors less than 2 centimeters, and little bit of controversy on those with lymph node involvement, even though they were included in some of the randomized trials. So what about side effects? So during actual radiation treatment, what we call the acute side effects that occur during or even shortly after, the main side effect is radiation dermatitis, or redness of the skin. Sometimes it can go on to peeling or desquamation, and we give patients recommendations on how to take care of the skin during and after treatment. Over time, sometimes those, particularly with darker skin, can get a little bit hyperpigmented, where it turns a little bit darker, and that may take several months to resolve. Some women will experience fatigue during radiotherapy, particularly those who came off of chemotherapy, whereby their baseline is already a little bit depressed. And then sometimes patients will have some breast swelling or breast aches. Now, we always discuss with patients the risk of pneumonitis or inflammation of the lung, but that is a pretty rare risk, particularly if we're treating the breast only, and particularly if we're treating only the partial breast. Late toxicities that we discuss with patients can occur months or years later, and that can be fibrosis or hardening of the breast, including shrinkage of the breast tissue, development of skin changes, telangiectasias, which are broken blood vessels of the skin. Sometimes over time, the cosmetic appearance can decline, so patients may note that several years later. And one thing that fortunately we don't see as much anymore, but something that we're very attentive to, is the risk of lymphedema, which you can see kind of not a very severe case in this picture here. This risk has decreased over time, fortunately, as we've introduced sentinel lymph node biopsy, as it's often related to the number of lymph nodes that are resected. But certainly when we add radiation to the lymph node areas, we have to be attentive to increasing that risk as well. We don't really see rib fractures very often, but we do discuss that. And of course, cardiovascular disease is something that everyone with left-sided tumors is worried about. And we will use our treatment planning techniques to try to minimize dose to the left anterior descending artery and the left ventricle to decrease that risk. And we always disclose with patients that there's a rare risk of secondary malignancy. With the treatment of breast cancer, it has been most noted to be a sarcoma, or angiosarcoma being the most common sarcoma that may occur in the breast. Now, where are we today and where are we going in the future? There are several ongoing trials that are looking, as I mentioned, at omitting radiotherapy after lumpectomy. The one I mentioned was the ER-positive tumors with a low oncotype, but there's actually an ongoing trial that's about to open here at Stanford, looking at low-risk HER2-positive tumors treated with HER2-targeted therapy that may be able to safely avoid radiotherapy also. Now, I didn't talk too much about regional nodal irradiation or post-mastectomy radiotherapy in patients with positive lymph nodes, but there are a couple trials looking at that as well. I have a slide for that in a second. I mentioned hypofractionation primarily in the post-lumpectomy setting, but there are also emerging trials looking at this in the mastectomy setting. So we may start to utilize these shorter courses of treatment even when we're treating the chest wall and regional nodes. And of course, almost every consultation, I end up hearing questions about proton therapy. So the trial that I wanted to just kind of comment on is looking at women with lymph node involvement or T3N0 tumors. So those are tumors over 5 centimeters without lymph node involvement. And the question is now, can we identify biologically low-risk tumors that might not need regional nodal irradiation? So this trial, the Taylor RT trial, is looking at node-positive or high-risk node-negative patients with a low oncotype score, and they're randomly assigning them to no regional radiation after breast-conserving surgery, so it would be breast radiation alone, or in the post-mastectomy setting, no radiotherapy at all. In those, otherwise they're randomized to the addition of nodal irradiation or comprehensive chest wall and nodal irradiation. So this is really trying to get at the question is, can we look at these node-positive patients and select out biologically which ones might be able to safely omit additional radiotherapy? In the neoadjuvant setting, so this is in the setting where patients have a known positive lymph node, they get neoadjuvant chemotherapy, and if at the time of surgery their lymph nodes are negative, these women are being randomly assigned no additional radiotherapy, so whole breast alone and mastectomy, no post-mastectomy radiotherapy after mastectomy, or the addition of regional nodal irradiation or comprehensive chest wall and regional nodal irradiation. Again, trying to better identify or individualize treatment for those who have lymph node involvement, but may do very well without radiotherapy. And the proton question, as I mentioned, is an ongoing trial here in the United States, randomly assigning women to photon therapy or proton therapy with the primary endpoint of looking at cardiovascular events. So we'll be hearing about these trials in the near future to help better guide us. So in conclusion, I just wanted to highlight that we're now looking at observation or no radiotherapy for some patients where we're now understanding that biologically their disease might be lower risk than what we thought in the past. And for those who do want to reduce the risk of recurrence, we individualized the discussion about whole breast or partial breast for those with early stage disease, either DCIS or early invasive cancer. And now I think everyone would agree hypofractionation is standard if you're proceeding with whole breast treatment. We still have some ongoing questions about the addition of regional nodal irradiation or post-mastectomy radiotherapy for those with lymph node involvement. So we're learning more about that, and we'll hear about those trials in the near future. And as I mentioned, we're now incorporating biology to help better individualize treatments rather than just lumping everyone together. We're trying to stratify and individualize treatment recommendations. So with that, I'd like to thank you for your attention, and I'll turn it over to Jonathan.